Good morning. We'll wait a few moments till we have a few more people. Mm. All right, why don't we get going? This is going to be a brief one this morning. All right, this is a 16-year-old following surgery for tetralogy with absent pulmonary valve, and patient was fainting, and this is the tracing that was obtained in the EP lab. So why don't we ask Dr. Dr. Condon if she has any thoughts on what's going on here.
All right, good morning. Let's see here.
And since we don't have lines on the paper, let's just assume, for the sake of this conversation, that the ventricular rate in this patient is 52.
Okay. Alrighty, so we are okay. So if I first look at the surface electrogram, we are seeing in the first QRS complex, I guess I would say more like in the second one there's a P and a QRS. It's kind of hard to say what's going on from the surface, but if you go to the intracardiac, the first signal is from the His, and then, or I guess,
Let's just review the channels, right? We have 3 EKG channels.
Okay.
Have 2 RAs, a distal and a proximal, which is unusual. Normally, in our lab, we only display 1, but that's okay.
Okay.
Then there's a His, a proximal, and a distal His, and an RV.
Okay.
And it doesn't appear as if the RV is plugged in.
Okay.
So,
yeah.
So basically, we have 4 intracardiac channels and 3 surface electrocardiograms.
Yeah.
So what is this here?
Okay. So that's the R. That's the RA, like it looks,
right.
yeah, the
atrial depolarization. So here's an A, here's an A.
Yeah.
Here's an A.
Sure.
And what's happening in the His channel, though?
It goes RA and then the His, and then there is something after the
Well, this is the His, right? But
yeah.
is there anything after the His?
No.
Right. I mean, if it's hard on intracardiac to tell where the P wave is, right? Because the paper speed is much faster than on a 12 lead.
Right.
But because we have the intracardiac, we know that there's a P wave somewhere buried here. I guess this is like the P wave here in lead 2.
Okay. Yeah.
But you notice that we don't see a QRS.
Okay. Yeah.
And then here we have another A.
Yeah. And
we do see a QRS.
Yes.
Here we see an A. And we don't see a QRS.
Okay.
So my question to you is this block in the AV node, or is this block in the His-Purkinje system?
I think in the AV node.
You had a 50.
Okay, so it's in the His. Okay, gosh. Sorry.
Now, the reason, right? Remember that we believe that conduction we can't actually, in standard electrophysiology recordings, record an impulse from the AV node. I believe it's believed or has been shown that you can record AV nodal conduction in a electrically silent space, but the bottom line is in a standard clinical laboratory, we can't. So what we do is we can record, though, an impulse from the His. And we can record the atrium. And we assume that the interval from the atrial depolarization to the His represents the AV nodal conduction. And
Okay.
then once we see the His, we then assume that the interval from the His to the V represents the His-Purkinje conduction. And
Okay.
so if we see an A and an H, but we don't see a V, then we can generally assume that the AV node is actually intact, but the His-Purkinje system has some issues, right? Because
Yes.
it's not conducted. This is an unusual tracing. You don't see this very often. So the bottom line is we have an AH and then an H and no V, and then an AH and a V. And the other notable fact here is, I understand it's hard for you guys because you're not used to seeing these types of tracings at this paper speed, but this is a long PR interval. And the other thing that kind of gives it away is, what is the normal AH interval and the normal HV interval in most people?
I think that so the normal AH, is it about 100?
Yeah, well, it's between 55 and 120. So it's a pretty wide range. And
Okay.
what's the normal HV? Is it longer or shorter than the AH?
It's shorter.
Yeah, it's much shorter.
Yeah.
It's usually like 35 to 50 milliseconds. So
Yeah.
when a person has a normal AV node and His-Purkinje conduction, the AH interval ought to be a little longer than, equal to or longer than the HV, but usually longer. This is notable, right? Because the H to V interval and the A to H interval look almost the same. And in fact, you could make an argument just from your eyeball that this interval here from H to V is in fact longer than the AH, although marginally, but clearly this is very abnormal. And so this child had infrahissian block. And it's important to remember that this is the type of block that we believe children get when they have open heart surgery and have injury to their conduction system. And this is considered a higher degree of AV block than if we were seeing block in the AV node. And I think in a child who has postoperative heart block, albeit 15 years later, this would be considered, I think, an indication for a pacemaker in most cases.
Does it usually take that long to manifest?
No, in fact, it's very unusual that this is the case. It's very strange that this would happen so many years later. It's not unheard of. I think I'm even an author on a paper from a number of years ago, in which we looked at children who developed heart block late following congenital heart surgery. And we did, in fact, see that there was a subset, a small group of patients who actually developed heart block, like 10 or 20 years after open heart surgery, and trying to look for predictors of that. I've often wondered if children who recover their conduction very late, right? All of us have seen, I think in the last few months, we had a patient who came back at like post-op day 8 or something like that, or 9. In that case, we ended up not placing a pacemaker because the child was very sick and was in the hospital for like another month. And so we were able to monitor the conduction continuously in an observed state, a monitored state, and never saw any further conduction problems. But that patient would be someone that we would at least have a higher degree of concern about. So.
Gotcha. Thank you.
Thank you. All right, let's move forward here. So this is a case of a child who has a history of tachycardia, is in the cardiac cath lab, and the patient has the RV catheter is in place, and the doctor has placed the coronary sinus catheter in, and in the process of placing the coronary sinus catheter, tachycardia suddenly begins. So the His catheter is not in place. There's some artifact here. I don't know what that is. So the question I have for you is, it's the tachycardia starts suddenly. Can you make any guesstimates about the mechanism of the tachycardia just based on the fact that we have this coronary sinus catheter in place? And so again, I'll remind you, we have in this case 4 ECG channels. And again, I always remind you when you're looking at intracardiacs to look at the legend on the left-hand side of the screen. So we have 4 ECGs. We have 2 ablation channels or MAP channels, which is not being used at the time. High array has not yet been placed. The HIS has not yet been placed. We have coronary sinus from proximal to distal, and then we have the right ventricular apex catheter, which seems to be in position. So, Molly, based on what we're seeing here, is there any clue as to what the possible mechanism for this tachycardia is? Can the electrophysiologist make a guess right off the bat without having done anything other than placing an RV and a coronary sinus catheter as to what the mechanism is?
I bet the electrophysiologist can and did make a guess.
Okay.
We'll see what Molly makes a guess of. So if you're just placing the CS catheter and inducing it, it makes me think that the pathway is near or along where you place the catheter. Like if it irritated it as you placed it.
Well, let's take a step back. That's false.
Okay.
Because I mean, you might be thinking that's what I'm trying to get you to say. So I apologize if I'm misleading the witness here. But you know, tachycardia can start, right? What starts tachycardia? It's usually a premature atrial or ventricular contraction, right?
But if it's like tickled by the catheter, I guess is what I was thinking.
Right. Well, it was probably tickled by the catheter, but the fact that the catheter happened to be being placed into the coronary sinus doesn't actually PAC. There's no evidence to my knowledge that PACs or PVCs that occur near to a substrate of tachycardia are more likely to cause tachycardia. That would be an interesting study, but in my clinical experience, that has never been the case. I don't believe that's the case.
Okay.
It's usually timing, right? It's the number of milliseconds after the last sinus beat that carries, and the refractory periods of the pathways that determine that. So yes, we've agreed that this was a PAC that induced this. So anything you can guess from this tracing?
I'm not sure.
Well, what do you make of the ventriculoatrial timing? Can you comment on that? When the coronary sinus catheter is in place, remember that it sits on the mitral annulus. One of the great things about a coronary sinus is it allows us to record both the atrium immediately above the coronary sinus and the ventricle immediately below. So the CS allows us to, I think in one of Ed Walsh's old book chapters, it says it's God's gift to the electrophysiologist because it gives us a peephole into the left atrium. But it also is nice in that it provides us a very stable location to put a catheter that allows us to monitor atrial and ventricular depolarization and the relationship of one to the other. So when a catheter is in the coronary sinus, we know that there's an A and a V on it. And so my question then would be, can we make any determination based on the interval between the A and the V or the V and the A in terms of a mechanism of tachycardia? So most cases of SVT in children are, what is the 2 most common in the differential diagnosis of a child who has SVT?
So it'd be AV nodal reentrant tachycardia or AVRT.
That's correct. And which one is more common of the 2 you just said?
AVNRT.
Actually, it's the reverse. You may think it's AVNRT because it just happens that for like the last year and a half, I've probably done 90% AVNRTs, but in reality, and maybe there's something in the water that's making that become the reality, but actually AVNRT in general is roughly a third of pediatric SVT, or 40%, whereas ORT or AVRT is about 60 to 70%. Okay, so if we were going by the VA interval or the R to P interval, how would we distinguish those two?
So you look at, people have kind of different, I guess, criteria, but like longer, if the RP interval is longer, it's more likely to be AVRT, whereas if it's shorter, it's more likely to be AVNRT.
That's exactly right. So can you make any comments based on what you're looking at here in the coronary sinus as to the mechanism based on that criterion?
Yeah, well, so I guess like, because when you're looking, because there's more of a distance between, like when you're looking in the CS distal, like to me, because proximal looks extremely close, which looks like then that would be like, it's a little hard for me to appreciate with the like track speed, but and the proximal looks really close, which make me think like AV, NRT, but then I don't know, in the distal, it looks like it's farther.
That's a very, very good observation. So just so everyone's on the same page, what Molly is saying is that in the proximal coronary sinus, it looks like the R to P interval or the VA interval is less than 70 milliseconds or short, but in the distal CS, it's quite a bit wider. Now, the important thing to remember is that you don't really, it's possible that this could be a pathway, but usually, even with a pathway, you would expect that the R to P interval would be a little bit longer.
Okay.
So first of all, if someone had AVNRT, then the reentry is occurring in the AV node itself, and then the entire rest of the heart is depolarizing passively from that location. So we would expect that the CS distal atrial impulses would be later than proximal, just because the proximal is physically a lot closer, right? Now, it's true, if I had if the pathway were located right on top of the CS proximal, the ablation catheter, and the pathway was located at the CS proximal location, which would be in the posterior septal region, then the RP interval would be short at that location. So the short answer is you can't really tell for sure, but it is suggestive that this is AVNRT, because there is somewhere on this page an RP interval that is very, very short, and the pattern suggests that it's closest to the mouth of the coronary sinus, or at least closer to the right side of the heart than the left, right? Because the left side is getting progressively later. Now, do we know that this is definitively AVNRT from this? No, we don't. We would need to do multiple other tests to prove it. But when I see something like this with such a short R to P or VA interval right at the start of the procedure, I start thinking that this, so that at this point, I would say that there's multiple things that could be in the differential, but amongst AVNRT versus ORT, which are the two most common mechanisms that account for 95% of SVT in kids, I would at least be thinking first in my list would be AVNRT, and second in my list would be ORT with a pathway that's close to the coronary sinus, allowing the VA interval to be this tight. But usually, because these intervals, these RP intervals and VA intervals, are intended to be for surface electrocardiography, not when you actually have a catheter sitting directly on top of the pathway. So now one of the ways that we could also check to see if this is AVNRT, we haven't discussed this very much, is people who, when they're in AVNRT or ORT, the R to R interval seems pretty fixed. But it turns out that in AVNRT, there is what we would refer to as cycle length oscillation, meaning that if you measure the R to R interval in a patient with AVNRT, there's often between 5 and 10 milliseconds of interval between each one changes. Whereas in ORT, it's anywhere between 0 and 2 or 3 milliseconds, much more fixed. Clinically, they both look fixed, but a little clue is to look for cycle length oscillation. And I didn't do that at this point in this procedure, but that is a possibility. So when one sees this, or when I saw this in the case, I had a suspicion that this was probably AVNRT. I believe in this case, it was ultimately determined to, in fact, be AVNRT. But that had to come from multiple other tests. So you see that we would not just go ahead and do a slow pathway just based on this finding alone, because we still don't really know definitively what the patient has. And of course, you don't want to be burning near somebody's AV node unless you're pretty darn sure that
Mhm.
you have the right diagnosis. So that was a good analysis, Molly.
Thanks.
All righty. So this is postoperative day 12 following an AV canal repair. This is an old tracing. And the person who created this said that V1 and V4 are atrial electrograms. And my question to you is rhythm with question mark. Rhythm? What is the rhythm that we're looking at here? So why don't we ask Dr. Mukhopadhyay, fresh from a restful weekend, which is
Good morning, Dr. Pass.
good morning.
I'm looking at the rhythm strips, looking at two, and I can't make out the P wave for the first QRS, but it's apparently for the first, for the second QRS,
Mhm.
I don't think there's a P wave, and for the third one, maybe there is. Okay, there's an
Now remember, you have an atrial electrogram,
right.
and you always have to think: is there a P wave buried in a T wave, possibly? This is
Right.
nice because somebody has very nicely labeled what they've done, and has nicely created for us an electrogram, which should clarify the relationship of the P waves to the QRSs, or if there are in fact P waves.
Right. So, so because of the atrial electrogram, I would think that there are like P waves buried in the T wave, and or after the T wave, or
So for example, this is V. It says that V1 and V4 are atrial electrograms. So we have a rhythm strip here, right? So I
yes,
think we would agree this is a QRS, right?
yes,
And so we know that everything on this page is simultaneous. That's the way this particular EKG machine works. You should always be aware that there are some that put the rhythm strip as a different strip than what's actually happening above, which I've never understood. But thankfully, ours are programmed to all be simultaneous. Okay, so this is clearly the QRS. So everything we look down from there is a QRS, which means that everything else is not. And we look in V1 and we see this very large, sharp signal, which does not look like anything we normally would see on a surface electrocardiogram. So this is the electrogram, right? So this is the atrial electrogram, because someone has told us that they've attached the atrial wires to V1 and V4. So we're on V1, and we know this is the QRS because we're looking at leads that don't have the electrogram attached to it, and we see clearly this is the QRS. So when we're coming down here, this is the QRS and this is the A. And you always have to remember, when you're recording an electrogram directly from the heart, the impulse on the paper or on the monitor may look very, very large, and even larger than the QRS, because remember, you're directly recording it from the myocardium. So it's a little bit odd to look at a tracing where normally, of course, the P wave is tiny relative to the size of the QRS, but because we're recording directly from the atrium, we have a large atrial electrogram. So we see QRS A, V, A, V, A, and then no V. Then again, A, V, A, V, A, V, A, no V, and so on and so forth. So what would we call this?
we'll call this.
Is this first degree block or third degree block?
This is neither. This is like a second degree block, and the PR interval is not increasing for these beats, and there is like 3 beats where the P wave is followed by the QRS, and then there is the P wave which is not followed, and there's a drop. So I would say this is a secondary heart block type 2.
So this is a hard answer or hard question to answer because this is the disadvantage of doing this on Zoom. And by the way, I'm always happy to switch it back to doing it in the room together. I've continued this on Zoom because Dave Barris thought it was easier to see the tracing. So it's all up to you guys, and you can tell me how you'd like to do this. But in fact, there is in fact a subtle increase in the PR interval. It's from here to here. The other thing that often goes with, and this is a good clinical pearl to go forward, is when you see block and it's in a grouped fashion. So you see 3 beats in a row, then a block, 3 beats in a row, a block, 4 beats in a row, and a block. When you see this type of grouped beating, almost always that's a sign of Mobitz 1 block. Okay. This is a very good, it's a good clinical pearl. So even if you didn't have the entire top of this tracing, all you had was leads 2 and V5. If I saw a couple of beats, some block, a couple of beats, some block. Now, just looking at these tracings, it's very hard to know that there's a P wave in that T wave, right? You could just think these are somewhat peaked T waves. You do see a P wave here, but then you don't really, it's hard to know what the T wave looks like without the P wave on top of it, because we don't ever have a T wave that doesn't have a P wave on it. But I guess what I'm trying to say is just seeing the group beating, as I'm seeing here with block in between it, would be at this type of a rate. So you could have group beating with sinus arrhythmia at slow rates, but this is much faster, obviously. The R to R intervals on the conducted beats are around 150 beats per minute. So what this is actually, I would be thinking about whether this is a Mobitz 1 block, just based on the presence of the group beating. And then once you see the atrial electrogram, you can see, in fact, that when there is a pause, it's because there is non-conduction from the atrium to the ventricle. So we're post-op day 12 with this arrhythmia. What would you do for this patient? Does this patient warrant a pacemaker? It's some kind of second-degree block. We think it's Mobitz 1, could be Mobitz 2, not sure. Probably Mobitz 1. And I might add, this question has no right answer, so I'm just asking your opinion.
So this is a 5-month-old male, and the rate is like around 130s with Mobitz 1 second-degree heart block. I would just observe it.
Yeah, I mean, there's no right answer. One could argue that this could progress, right? One could argue that it might improve, but probably this is not a dangerous rhythm, particularly since it appears as if conduction is not bad. For example, I'd want to know what happens at 120. Maybe at 150, this heart rate is like 155 in the atrium. Maybe at 147, the patient conducts 1-to-1. So I think a lot of it would depend on what the fastest or the best 1-to-1 conduction in this patient is. If the 1-to-1 conduction can go to 150, in this case we're at like 155, but what we don't know is if it was at 150 or 147, would it conduct 1-to-1? And I think although that is not normal to start Wenckebaching at a rate above that, it is probably safe enough that we could send a patient home like that with close observation. So I agree with you. I probably would not put a pacemaker in such a patient. I would watch them carefully, and I'd want to see on telemetry what happens at slightly slower sinus rates. For example, what's the heart rate when the patient is sleeping? Also importantly, are there times of higher grade block? We're seeing here what we think is Mobitz 1. It could be Mobitz 2. Are there periods where it appears as if there's no conduction at all? That can be the case. You can have intermittent changes in the conduction. One of my early mentors used to say that he felt more comfortable if it was third-degree block because he knew what the patient had. And when you have second degree, it can vary. And so you don't really know what the natural history of this rhythm is going to be. So for sure, whatever you do, the most important thing is to continue to monitor this patient very carefully because it could change. But I think in a case like this, I think most would probably observe this patient in the hopes that as long as there's conduction up to about 150 beats per minute, probably the patient will clinically be fine. Any questions about that? All right. I think we're going to stop here. Thank you very much, and I'll see everybody in sign out in just a short while.
Thank you.
Thank you.
Thanks.
Have a good day.